Welcome to this very special convening on activating healthcare assets for housing and health equity. I'm Warren Hansen, president of Greater Minnesota Housing Fund. And many of the housing practitioners here today are already familiar with Greater Minnesota Housing Fund, but we are intentionally expanding our traditional affordable housing network to connect with the healthcare community, in particular, around innovative housing and health equity models. For the benefit of the healthcare folks, Greater Minnesota Housing Fund is a nonprofit intermediary that provides low-cost capital in the form of grants, loans, and equity investments for affordable housing of all types, including supportive housing with services, preservation of NOAA housing, as well as the production of new workforce housing and single-family starter homes. We also undertake special initiatives like this statewide housing and health equity initiative that's designed in part to establish a cross-sector learning community in order to coordinate housing and health investments by healthcare, philanthropy, government, and impact investors. Over the near term, we will be focused, along with many of you, on creating a learning community to build a strong statewide network of healthcare institutions and housing organizations who work together to create stable homes and healthier families. And toward that end, today we've pulled together an incredibly unique mix of healthcare, housing, and service providers that we're going to hear from in just a few minutes. I wanted to mention that many of you may remember that we first gathered a little over 2 years ago in person for a health and housing summit, which was held on February 25th, 2020. And we had over 150 healthcare and housing leaders who spent a whole day together learning from national thought leaders and Minnesota experts about health and housing models. But of course, just 2 weeks later, in early March 2020, we all know what happened. Within days, our partners in healthcare were swamped with more urgent and heroic work as the COVID-19 pandemic swept through our community. But today, 2.5 years later, we gather again with the same bold agenda to foster greater health equity through stable housing and more equitable communities. One of the biggest lessons we have all learned from the pandemic is that the link between housing, health, and equity is indisputable and explicit, and that this work needs our combined and coordinated efforts to create more stable and healthy homes. And as we said repeatedly at the 2020 Health and Housing Summit, we know that this works. For decades, our affordable housing partners and service providers have worked together project by project to create permanent supportive housing throughout Minnesota, with every project changing and saving lives and proving again and again the profound and effective relationship between stable housing and better health outcomes. Most of the developments that Greater Minnesota Housing Fund and Minnesota Housing Finance Agency provide resources for include permanent supportive housing with services, including, I'll just mention two, Steve O'Neill Apartments in Duluth, which was a 44-unit supportive housing development for families with children and includes a homeless shelter operated by Churches United in Ministry, or CHUM, on the first floor. Just a great family project that is changing and saving lives, including those of children and infants. Also, there's a project by Avivo that we were able to finance. Avivo is the chemical health recovery organization that's based in Minneapolis and also operates in St. Cloud. Avivo acquired 3 NOAA apartment buildings for their residents to receive stable housing and medical services that are essential for recovery. So with that in mind, I'm happy to kick off the Housing and Health Equity Forum today and introduce our co-host of the event, Lucas Ness, President and CEO of the Minnesota Council of Health Plans. Lucas, it's all yours.
Well, thanks, Warren. While we weren't part of the discussion 2 years ago that you referenced, certainly really glad to get invited here and co-sponsor today and take part today and in the future. So my name is Lucas Nessie. I'm the President and CEO of the Minnesota Council of Health Plans, as Warren said. We are the state trade group for Minnesota's nonprofit plans, including Blue Cross Blue Shield of Minnesota, Health Partners, Medica, UCare, and Sanford Health Plan. So our member plans take very seriously that many of the factors that impact health and well-being happen outside of the medical system. I'm sure you've all seen the studies that show that social factors such as reliable transportation, nutrition, jobs, and stable housing can determine up to 80% of a person's health outcomes. We also know that stable housing is one of the most impactful ways to quickly improve health. Studies have shown a 45% drop in health expenditures after just 6 months of moving into stable housing. It's just an incredible statistic. So all of Minnesota's nonprofit health plans, as mission-based organizations, have long been actively engaged in the community on those important topics and more. For example, Health Partners has shown a strong commitment to Habitat for Humanity, where they have built nearly 30 homes for local families in need over just the past few years. The Medica Foundation works with YouthLink, a Minneapolis nonprofit that connects homeless youth with community resources to meet their immediate needs and help them build stable futures. And the UCare Foundation supports dozens of local community organizations, including those dedicated to improving health outcomes in underserved and diverse populations. So there's simply just a lot of great work going on. You'll hear much more about community initiatives directly from our member Blue Cross Blue Shield of Minnesota and others later this morning. Finally, we know that social risk factors don't have the same impact on everyone across the board. We have to recognize where disparities exist and where interventions need to be targeted to make sure everyone has an equitable opportunity at achieving their optimal health. And that's why the council is so pleased to be co-sponsoring this discussion today, so we can build upon all the great work that is underway. We are really confident that closely collaborating and building even broader coalitions will make an even greater impact for our community. So thanks, Warren. Thanks to everyone for putting this event together. Thank you to the panelists for the work that you do and for taking the time to participate. And I really look forward to the discussion. With that, I want to hand it over to Eric, the Director of Housing and Health Equity at Greater Minnesota Housing Fund. Eric, over to you.
Thank you, Lucas. I really appreciate you partnering and co-hosting this with us. So I get the pleasure of introducing our speakers and guests today. But first, I want to share some new developments around the Housing and Health Equity Initiative. Today's event is activating healthcare assets for housing and health equity. And you'll hear several examples of ways that healthcare partners are using their multiple assets toward upstream solutions to community health. Not just financial assets, but knowledge, relationships, data, information, influence, and voice. It feels like a really good time to recapture momentum started by the statewide conference so long ago, but with increasing recognition of the housing health connection through COVID. There's a few key shifts in the initiative that I want to recognize. First, that housing and health is more than permanent supportive housing or service-connected housing. Now that's core and mutually beneficial link that we need to expand and we need to build on. It's all housing, though, that provides greater stability, and housing in relation to other social determinants of health like safety, food, security, and economic opportunity. That is so important. In addition, given the wide exposure of health disparities that we documented and exacerbated through the pandemic, we know that health equity is inseparable from advancing housing and health partnerships. Today, we have a great mix of folks in the room. We have about a third housing participants, about a third healthcare, and a third of government and other participants. And in the housing category, we have a better breakdown of this, but a third is a good way to think about it, and that's really important. In the housing organizations, we have for-profit, we have nonprofit developers, and owners of housing. In the healthcare category, it includes health plans, hospitals, clinics, federally qualified health clinics. And in the other and public sector categories, there's philanthropy, there's financial institutions, and there's key service providers, especially related to permanent supportive housing. We also have been collecting data and information through surveys on the importance that you have in the field. In March 2022, we asked about the topics of interest related to housing and health connections, and the results provide us some guidance for the Housing and Health Equity Initiative that we can focus on to meet your interests related to the topics. And what we learned was 100% of respondents said it was time to convene again. So we are convening, but there were 27% that indicated virtually only, so we're going to start that way. 50% are saying that the link between housing and health equity was made clear and inseparable by the pandemic. 60% of respondents indicated that institutions had increased motivation to pursue projects, initiatives, or strategy that connected housing and health equity. Now, we also asked about the highest areas of interest and topics. And what we found was new research on housing and health equity connections was important. Best practices and lessons learned nationally and in Minnesota was important. That's what we're doing some today. Innovation and advancements in permanent supportive housing. Medicaid reform for housing supports, which is an event that we may be holding in July of this year. And then interestingly, anchor institution developments actually was the largest increase from the pre and post survey. So there was a lot more interest in anchor institution developments. Finally, we asked for ranking of the list of social determinants of health impacts on health and wellness. And the top 3 categories were economic stability, community and social context, and neighborhood and physical environment. So with survey results, and we actually had about almost 250 people register. I don't know, I think the number is probably 150 or 75 that's on the call right now. But that actually exceeded the number that registered for the conference 2 years ago. And I think we can call this the official reboot of the Housing and Health Equity Initiative. So the initiative goals remain pretty much the same. First and foremost, we want to create and build a community of practice, a place of knowledge sharing and learning as a community. From that, we want to foster an increased pipeline of housing and health equity projects and partnerships. We especially want to catalyze further investment into this arena with a desire to create a large $50 to $100 million fund that builds new low-cost workforce housing, preserves naturally occurring affordable housing, and supports a growing number of housing and health equity projects. We are committed to collecting and documenting research and promising practices as the case studies that Warren referenced. And on our website, we have more. And of course, with your help, we will identify opportunities for policy and systems change to advance housing and health stability. So now I am very excited to introduce our featured speaker for the day. Robin Hackey is the co-founder of the Center for Community Investment and is at the forefront of thought in healthcare and housing partnerships and developing mechanisms to deliver additional capital to social determinants of health and housing in particular. Center for Community Investment's capital absorption framework is being used throughout the country to increase the delivery of capital resources to underinvested communities and communities of color. I'm so pleased Robin is here and to share the experience and learning and building bridges to healthcare assets and investments. So Robin is going to, actually, we do have a slideshow that we're going to share after the presentation in an email. And I also want to encourage people to write questions in the chat throughout the conversation. We will be picking those up. If we can't answer them today, we'll be answering them at a later time. Robin can respond in time sometimes. She's that talented. We will also have at the panel, we want to look for questions. And Catherine McCarthy is going to be collecting those questions and helping narrate a Q&A at the end of the session. So thank you. And with that, I want to turn it over to Robin.
Terrific. Well, thank you, Eric, for the invitation. And thank you also for taking down that slide of pre-COVID me. You see what difference 2 years makes. I used to have darker hair, and that's a thing of the past at the moment. It's wonderful to be with you, and I'm excited for the adventure that all of you are embarking on together, forming a community of practice in this area, which is just so important. The Center for Community Investment was formed 5 years ago now to try to figure out how we can help people thrive and achieve equity without just treating the symptoms of what causes inequity and health outcomes to vary in our country, and really to think about how do we deploy capital and how do we change systems so that we address where people live and the conditions that they need to thrive. And so when we have been thinking about how to do that, and I'll talk about some of the programming that we've done, part of the deal is to really think about who are the institutions in our society that have significant assets that really haven't been players in the community investment game in the way that they could be, given the alignment of mission. And when we started out 5 years ago, it became really clear that the health sector, with its growing awareness of the importance of social determinants, the growing awareness of the root causes of poor health, really could be thinking about what it would look like to act upstream. And so we were given a grant by the Robert Wood Johnson Foundation to create a 3-year initiative called Accelerating Investments for Healthy Communities. And what I'm going to talk to you about today are the lessons learned that came out of that initiative, and the examples that the participants in that program have really generated for the field, which I think are pretty instructive. So Accelerating Investments for Healthy Communities was an effort to learn from and with the leaders, right? Right now, there really is not a requirement for health institutions, whether they be plans or hospitals or other forms of institutions, to invest upstream. So if they're nonprofits, there's a community benefit requirement, but it's not a hard and fast requirement. It doesn't specify a dollar amount or a percentage. And people do what they do with that investment of community benefit dollars. It's grants. They, have a golf tournament on one end of the spectrum, or they make donations to local groups. A whole variety of things count for community benefit. And so what we were really looking for in the Accelerating Investments for Healthy Communities initiative were the institutions that had gone well beyond what was required by statute or regulation to use their assets to invest upstream in affordable housing. So these were the folks that were exemplifying the saying that I love, which is the future is here now, it's just not evenly distributed. So these were the folks like Dignity Health, now called Common Spirit, like Kaiser Permanente, like Boston Medical Center, Bon Secours Mercy Health, Nationwide Children's Hospital, that were, and the UPMC, health insurance folks at UPMC, that were already doing something upstream that they didn't have to do. And the idea of the program was to bring them together, let them learn from each other, have them assemble teams for implementation in a designated geography, and each system picked a place where they were going to be concentrating from inside their service area, and then to let it roll and see what unfolded. And what unfolded was actually really, really interesting in a number of respects. The first thing was just the motivations, and what people expected to get out of doing this kind of work, which is not required. And I think we went in with a hypothesis that said that if people were going to use investments, and when I say investment, I'm not talking about, we invest in our children's future, but they don't actually write us a check to pay us back. I'm talking about financial investments that at least return principal and may also have an additional modest return. So these were folks who were deploying capital either in the form of debt or equity or other forms, but they were expecting to get it back. And initially, the hypothesis was that they would primarily be looking for some kind of financial return, which would be additive to the returns that they get in other ways. And maybe those returns would come from savings, like we're not going to see people in our emergency room a whole bunch of times. They might have been focused on what get lovingly referred to as frequent flyers, who are maybe experiencing homelessness, or they are kids living in conditions that promote asthma. And so we expected there to be a lot of focus on interventions where there would be a pretty immediate saving in terms of healthcare costs. And what we learned, to our surprise, is that that was not at all what these leaders were up to, which is not to say they were not doing those kinds of interventions. They certainly were, but what they were doing went well beyond the kinds of interventions where measuring an immediate health return was the goal. So what we found were that there were two really important kind of critical motivations that were at play. The first was simply, and especially for the faith-based institutions, that this is our mission, and that as soon as we understood the link between wellness and health and upstream determinants of health, we couldn't go back to a medical model where all we do is react to people who are sick. And so for the mission folks, when we asked about their motivation, they were kind of insulted. And it was just obvious to them that this was work that needed to be done. And the question was not whether, it was how much and what kind. So that was one group of folks. Interestingly, beyond the faith-based institutions that you might expect to have a strong mission orientation, because the sisters said, we also found in that category lots of children's hospitals, because it turns out that a lot of the leaders in this area are pediatricians who see the long-term health effects on kids of being not stably housed, not housed in healthy conditions. And so we also found a very strong mission orientation among pediatricians. So the two clinical specialties that really do this the most are the emergency room docs and the pediatricians, which was interesting, not something we expected. The other motivation, and this was the one that was by far the most important, was what we started to refer to as institutional imperative. And what did that mean, institutional imperative? It meant that the health system was doing something where the respect of the mayor, the support of the community, the reputational value of being a leader was really important to that institution, either because they were doing a campus expansion, or they were doing a merger, or they were engaged in some contract bid, for an RFP, either from a government entity or a big corporate entity that was associated with socially responsible or impact investing. And so doing this kind of highly visible, not required investment was really a way for these institutions to advance their reputation and their standing in the community. And the more they were doing, the more they were motivated by that imperative, which was really not what we expected. So just putting that out there as a thing to be thinking about, because what it meant, which turned out to be quite important, was that engaging in investment as a team sport, which is really the way it ought to be done, was really super important to these institutions. They didn't land in a neighborhood with a single transaction or a single project and say, here we are, the saviors, we're going to fix you. They went at it in a way, and this increased over time, where they came in with a learning orientation, with a sense that for good reasons, there was not a lot of trust between community residents and these institutions, between the mayor or the city council and these institutions. And they came in with a set of questions about how can we help? And the more that was the initial orientation, the further they got, which was really interesting. So let me tell you a little bit about the kind of assets that they deployed and the ways in which they used them, because there was also, I think, quite a lot of surprises on that score. So the first thing is they learned to think differently about their grants and community benefit dollars. Many of them had been using them, as I said, in ways where they were supporting a large set of organizations. Every year, these organizations would get a check. That's a perfectly legitimate way to go forward, but it was not strategic and it was not leveraged usually. And so what these institutions started to do after they started asking the community about what the needs were, after they started talking to the mayors and looking at existing collaborative entities and seeing what the agendas were, they started using their grants as a way to unlock investment by others. And that could involve pre-development funding, that could involve market studies. They used those dollars in ways, and they were not always qualified community benefit activities, I should say, because there's a whole strict set of requirements of what qualified, but they used their discretionary dollars to unlock investments by others, and that turned out to be really impactful. So for example, Kaiser Permanente decided to work in Maryland along a newly being built transit line called the Purple Line. And they worked with Prince George's County, which is one of the 2 counties along that line, as part of a collaborative to look at how to improve the health of largely low-income and immigrant communities along that line. What they discovered, which was really important, was that there was a right of first refusal that the county had to purchase any affordable housing in the county that was up for sale that had never been exercised. So it had been on the books for almost 5 years. The legislation, the enabling was there, and the county had never figured out what would it take to exercise the right of first refusal, who would be the developers that we would turn to preserve these properties, what would it look like for us to support the rehab and renovation of these properties. So Kaiser Permanente, in conjunction with the Robert Wood Johnson Foundation, wrote a pretty modest check. This was, I think, $50,000 for a consultant to develop the RFP for the developers and to figure out what would it actually take to activate this policy that was already on the books. And since then, the policy has been used more than 3 times, resulting in successful transactions. It has preserved hundreds of units, which would not have been preserved as affordable absent this intervention. And so the bang for the buck factor, it was not about spending more money, it was about how the money was spent. So that was just one interesting example. Second example came from deploying debt, and the debt got deployed in various ways. So Kaiser Permanente, again, worked with a community development financial institution along the Purple Line, the National Housing Trust, to be one of these places that would finance the developers that were preserving these units. And so Kaiser invested $5 million. And interestingly, the source of that money was a donor-advised fund that Kaiser had set up at a community foundation that nobody even remembered existed. So the sources of the funds from inside the health institutions turned out to be all kinds of weird places: insurance reserved, donor advised funds, donor gifts that were prompted specifically by excitement about this new way of intervening in the community, operating dollars, endowment dollars from the foundation, all kinds of sources. In this case, it was a donor advised fund that Kaiser had created with one of their donations that they had gotten, and they put that money into a CDFI, which created a fund for investment along the Purple Line. Another example, Boston Medical Center, a safety net hospital, does not have a great deal of discretionary resource like most safety net hospitals. They really operate hand to mouth, but they had a requirement as part of a campus expansion that they had to devote 5% of the cost of that campus expansion to community benefit. And what they decided to do with that money was deploy it as 0% debt for a very long term, 30 years. And they deployed it into 3 different projects that had a mix of affordability, ranging from some permanent supportive units that were in the housing up to workforce. They worked with a number of different developers. So some of the investments were through an intermediary, some went directly to developers, and some went directly to projects. So what we found was that, again, sources were varied. The form of engagement was varied, sometimes debt, 0%, 1%, 5-year money, revolving funds, long-term money, 30 years. And then we also saw a way of working with partners that made the system go, oh, if the priority of the community is this particular neighborhood, guess what? It turns out we own land in that neighborhood, and we were about to sell it because it turns out, with telemedicine now being a thing, with people not going back to offices, we had made plans for that land, but we don't really need it. And so UPMC donated a parcel of land to a developer who was then able to develop a very nice affordable housing project with much deeper levels of affordability than would have been possible if they had had to acquire that land in any other way. So we've seen the use of land as a donation. We've also seen some of the systems provide long-term leases for the land and work with developers to create the housing that goes on that land, but there's actually not a transfer of title. And so we've seen that deployment of assets as well. The last form that was kind of interesting that I'll just mention is Nationwide Children's Hospital did an unfunded guarantee. So they used the strength of their balance sheet to make a $1.5 million guarantee, the base, which formed the base of a $15 million affordable housing fund. So banks and foundations came in on top of that guarantee, and they were able to unlock 10 times as much capital by giving a guarantee, which I am reasonably confident is never going to be exercised, because the underwriting and the soundness of the projects that are being invested in by that fund is not going to require their guarantee. But they were able to make that $15 million fund possible by using the strength of their balance sheet. And I might add that the CFO, who was the one who approved that use of the balance sheet, which was kind of an edgy thing to do, got promoted to be CEO of the system, Tim Robinson, on the strength of his leadership. And they have now taken on a second neighborhood in Columbus, Ohio, where they're based. And he has a great deal of support from his board, one member of whom just gave them $25 million to expand the work. So we got some happy deployment stories there as well. Let me just spend a couple of minutes on a few takeaways from the work, because this is 3 years, I could talk about it forever, but things to keep in mind. The first is nothing about us without us. This is the kind of work that is a team sport. It has to be done in partnership. The best work that we've seen is done with authentic and ongoing engagement with the communities that are most impacted by the work, and also with other employers, with the city council, with mayors, with others who are at the table trying to make this stuff work. You don't have to start from scratch in most places in the country. There really are collaboratives, so join. And if there's a necessity to lead, but otherwise you don't have to, right? So you don't have to start something if there's something already in motion. The second thing I would say is these efforts require ongoing staffing. They don't run themselves, and it's not an extracurricular activity. So there has to be somebody inside the institution as well as outside the institution who is waking up in the morning and thinking about these investments, building a pipeline, deploying the capital, making sure that the investments are being stewarded properly. So staffing turns out to matter. And this is not staff that tends to exist already in these institutions. So we've seen a lot of the creation of new kinds of positions and the recruitment of people who may not traditionally have thought of themselves as working at hospitals. Having a learning orientation is a thing. We found that in health institutions, the normal way to think about it is random clinical trials, expert orientation, doctor knows best kind of approach. There really is a cultural shift that's involved in doing this kind of investment work well. So the goal is not to replace the doctor expert with the finance expert. The goal is to put people together in a collaborative that brings out the best of everybody's skills and that recognizes that this is a learn as you go kind of effort. There are not people with the answer that's going to make sense in every situation. We can be inspired by these examples, but we shouldn't be thinking that we're going to replicate them, because no such thing in this area. And then last but not least, this is really a field where the perfect is the enemy of the good. And so what we found is the most powerful examples are generated by getting started and adapting as you go. So wish you all very, very good luck with this effort. I think it's super important, and I look forward to hearing your questions.
Robin, thank you so much. Please continue to write questions in the box. I wonder if you could answer a quick question from me, which is, so as I've started, because I'm I'm pretty new. I'm learning the healthcare system, which is as complex, if not more complex, than the affordable housing system. So we're talking about systems that have like deep things going on within it, and they're very complex. Do you have any advice for how to reach into the healthcare system, where to go, how to start that relationship, and how to build that strong partnership?
That's a great question. So what we found is that the community benefits folks are the most accessible and the most known to the community and the least powerful in their institutions.
Yep.
So they can help navigate, they can sometimes give you the lay of the land, but because this kind of work is not a requirement in most places most of the time, it has to be led by the CEO or the board. And so what I would say is this is about finding your way up through whatever networking or existing relationships. And I know Minnesota is, the capital of collaboration. So you gotta work the network to try to figure out how to get in as close to the top as you possibly can. What we've seen is that the work, when it happens and when it's done well, goes across many, many departments. So the real estate person gets involved, the clinical people get involved, the innovation people get involved, the finance people get involved, community health, but it doesn't necessarily start in any one of those places in a predictable way. So you have to sort of navigate each system, and they're like foundations. Every health institution is its own unique being, very idiosyncratic. They call things by different names. So working the network is the way to go.
Thank you. I wish it were simpler than that, but I know it's
we
not.
all do. We all do.
Right. So thanks so much. Those are really powerful examples, and I can see notes in the chat that are to that effect. So this is really helpful. Next, we want to do a panel of Minnesota-based healthcare institutions that will share their stories for advancing the mission through upstream solutions in community health. And we're honored to have 4 partners here. Anthony Stately from the Native American Community Clinic. Alexis, if you could put up that slide. John Swanholm from M Health Fairview Health System. Andy McMahon from the United Health Group. And Bukata Hayes from Blue Cross Minnesota. Now their bios are are on our website for the event itself, so I'm not going to repeat the bios or the many accomplishments and expertise that they have. So what we asked these folks to do is to tell us a story. And so we asked each of them to provide quick presentations that answer the following questions. Briefly describe your organization's commitment to housing and health equity, coming out of the pandemic and the racial reckoning of the last 2 years. Describe in some detail your most significant or effective project to address unmet health needs using your institutional assets, financial or other, to advance upstream solutions. Briefly describe activities to engage community-based partner organizations that would be effective in operationalizing partnership. And finally, briefly describe key lessons learned that we can all learn from on how to improve and take action in health and housing strategies. So those will be put into the chat, so they're there. We're going to start off with Anthony. And please continue to put questions in the chat box. We're pulling the questions and trying to pull them and keep track of it, although it is hard to track sometimes in the chat box. Again, Catherine McCarthy is going to pull those, and hopefully at the end we'll have some time to do the questions. So Anthony, we're going to kick off with you. So thanks for being here, and please take it away.
Miigwech, I appreciate it. Bougie relatives, Hamatakiapi. My name is Anthony Stately. I'm the executive officer of the Native American Community Clinic. I'm an enrolled citizen of the Oneida Nation of Wisconsin, a descendant of the Great Red Lake and White Earth Nations of Minnesota, and I'm honored to be the servant leader of this fine organization and giving you a talk this morning about our work. So let's just launch in. Next slide. So the title of my talk here is the response to a community in crisis. And I'm going to be talking to you about Native American community clinics expansion in health and housing, and our attempt to build a new health and housing campus. And this really is in response to directly, many of you, if you've lived in Minnesota in the recent years since 2018, you would have remembered that about 4 years ago, Minnesota saw one of the largest homeless encampments in its history, which is situated along Hiawatha Avenue and Franklin Avenues and Cedar in an area in a encampment that was called the Wall of Forgotten Natives. You can go ahead and go to the next slide. The Wall of Forgotten Natives generally, go back 2 slides. You can see that it was one of the largest encampments that Minnesota had ever seen, and the majority of those people living in that encampment, which started with a few tents around June-ish, July-ish, late spring of 2018. There were like maybe 16 tents there, I think, when I walked through the encampment for the first time. And by the end of the winter of 2018, right before the navigation center went up, there were approximately 400 people living in that 1 block strip of land in about 200 tents. And it was garnered a lot of local attention, statewide attention, even international attention. There were people that were carrying stories about the encampment in Europe and other places throughout the world. And it was a crisis of epic proportions that the state and the county of Hennepin had never seen before. Next slide. This next slide is just a lot of the media attention that was garnered throughout those months. There were a number of overdose deaths, other people with tremendous significant health care issues in the environment. NAC was one of the first organizations within the Metropolitan Urban Indian community to respond to that particular crisis. We brought healthcare services to the encampment through partnership models with both tribal partners and also other community health centers and a number of other social service organizations, Avivo being one of those partners. We partnered in providing healthcare services and then also spiritual care services to the people living in that encampment, and then later the navigation center. That partnership that we built with Avivo and Simpson Housing continues today. We've built a lot of our work on that relationship over the last 3 or 4 years. And as we pivoted in 2019, after the Wall of Forgotten Natives and people were able to get housed, we were able, through those partnership models with Red Lake Nation and a number of other folks, we were able to get the majority of those people, about 380 of those individuals, into permanent housing. The majority of those people continue to stay in and housed well into 2020, about the time that the pandemic happened. One of the things I think that we've seen over the last couple of years, because of the impact of the pandemic and then also the civil unrest, is we have seen some backsliding in our gains around housing individuals. We have, in 2018, about 12% of the state's homeless people were American Indians. Today, it's closer to 16%. In the metropolitan area, is about 26%. So about 1 in 4 of all people who are homeless are Native Americans, although we represent 1% of the entire population. And so one of the things NAC was able to do over the legislative session of 2019-2020, we were able to sort of put together a bill and get legislative support to get $3.8 million in cash to purchase the building that we've been operating in for the last 18 years. We partnered with Otto Bremer Trust and White Earth Investment Incorporated to help us make up the difference between the cost of the land and the money that we got from the state to purchase that building. And initially we were thinking we were just going to sort of remodel our clinic and make a more modernized footprint. We live in this building, or we operate in this building that's kind of Frankenstein together, and was hobbled together over the 18 years of our operations, grabbing space as it became vacant in this little strip mall. And so it really didn't function very well as an integrated model. We did our best to make that work. And over that period of time as well, during that same period of time, 2018 to 2020, we opened an intensive outpatient treatment program in partnership with Red Lake. We opened up a medication-assisted dosing clinic in partnership with Red Lake, leveraging federal awards that were significant and sizable, multi-year awards that allowed us to be able to expand our substance abuse treatment programming services to support this particular population of people. We also expanded significantly through a number of partnerships, including Bush Foundation and Otto Bremer and a number of other organizations that funded our harm reduction models. So we were delivering healthcare and other types of life-saving services to people living in encampments over the last 3 years. And one of the things that became really clear to us through that process was that we serve a population in the Minneapolis metropolitan core. An overwhelming majority of our populations that we serve in the clinic are people who are struggling with generational, so chronic homelessness or episodic homelessness, due in part a lot to things like highest unemployment rates we've seen among American Indians in a very long period of time. While the rest of the population in the state of Minnesota is starting to see some of those unemployment rates come down significantly because of the investments that have been made over the last couple of years. The unemployment rate for Native Americans remains rigidly high, much higher than it is for the rest of the population. And other kinds of things that we've been talking about, those social determinants. It became really clear to NAC that the primary thing that we need to sort of address in our community was the highest rate of homelessness or houselessness, as I like to call it, because Native people, we are on our homeland, so we're not homeless, we are houseless, and that is a critical issue for us to solve as we try to also make the population more healthy and well, and support them in that journey. And about, I would say, a year ago, as we started to plan the process of rebuilding or remodeling our clinic, we decided to pivot and use this big, huge parking lot that we have that primarily is utilized for the staff who work at the clinic to park their cars in. We decided we were going to build a brand new clinic at the front of the property. And we are going to, you can kind of go to like the second to the last slide, I think, is an image of the building we are going to build. We're modeling our footprint here based on this particular building that we just saw, which is the Minnow B building, the Minnow Visitor Clinic building, and the housing project that Red Lake built in response to the Wall of Forgotten Natives, about 139 units in this particular building. NAC is going to build a brand new clinic right at the center of the American Indian Cultural Corridor. The clinic will take up 1 to 1.5 floors and about 4 to 5 floors of housing above, and approximately 95 to 100 units of housing above our clinic. We propose to build a clinic that will, some housing that will also provide some respite and supportive units to individuals, and all of it will be affordable housing. We decided this because it was critical to us. It was, overwhelmingly and abundantly clear that unless, the greatest use of our land that we were able to purchase over the last couple of years is redevelopment. And it was critically important for us to do our part to solve this homeless problem, and also start to do things like provide affordable housing, livable wage jobs from people in our community that can work in housing and healthcare. We're partnering with the Wellington Group to build the housing project, and we've had long discussions with them about, and intentional discussions with them about our sort of approach to building this project. As we work through that relationship, Wellington has made a commitment to us that we're going to recruit people from our community to work in housing management, which is also going to lead to livable wage jobs for many people from our community. And we will build the housing as well. And the project collectively with a builder who has agreed to recruit people from our community and give them livable wage jobs. So the entire project is intended to sort of lift people out of homelessness and set them on a trajectory that will support them to becoming more healthy and more well than they currently are because of the conditions in which they live. So.
Anthony, thank you so much. This is a great developing story, and it's still in process. But the new building in the Native Cultural Corridor is going to be quite an impact on that cultural corridor to the inclusion of both the clinic and the affordable housing. Okay, I'm going to move forward with John Swanholm from M Health Fairview. If we can go, I know we're having trying to catch up on the slides, but yeah, there we go. So VP for Advancement and President of the Foundation at M Health Fairview. John, please take it away.
All right. Good morning, everyone. Great to be with you. Thanks for inviting me to participate. Anthony, great to see you. Done some partnership work, and we've also assigned just want to add a full-time RN over the last year, and will continue for a few years in the East Metro in St. Paul, focused on shelters and the unsheltered population. So a lot I want to present today, especially after Robin's presentation. And we are part of the Healthcare Anchor Network. It's a national organization, 80 organizations focused on many of the ones you heard from Robin, focused on local investing, local hiring, and local procurement. So that would be another presentation. And I did talk about that at the summit a few years ago. We helped plan the summit. So again, great to be back together with many of you folks. So what I'm going to focus in on today is, while we're doing a great deal of work daily, in our communities, focused on the social determinants of health and programming, Housing is Health platform that's emerging, our Food is Medicine program that's been underway for many years. I'm going to talk today about a project, a large project coming to fruition very soon in July, and that's the reuse or the repurpose of our St. Joseph's Hospital campus. So maybe if we go to the next slide, kind of how we got here. I got a not so gentle reminder from Eric that we're a little off time. So I'm going to intentionally go pretty fast here and just know that I'd love to have conversations with anyone after this. So, it was over 3 years ago where we began to engage deeply with community on our case for transformation in the urban core of St. Paul. And we all know the statistics, and that's shocking to folks still, that in St. Paul and around St. Joseph's Hospital, a 3-mile difference in down 94 to Mac Groveland could equal up to a 13-year lifespan difference. Consumer healthcare costs are spiraling out of control. Consumers can't bear the increased expenses. So the costs have been shifted to folks who simply can't pay. Our financial results, reflected and reflect the reality of the crisis. Expenses, pretty simple math, expenses growing much more quickly than reimbursements. So I'd like to think that while Washington remains, you could argue, a bit deadlocked, and the state, we chose to lead change. The status quo is unsustainable. It's our responsible as a community health system with the faith-based roots we have, and also to think about our large footprint. So our service areas cover roughly 80% of the state of Minnesota. So we need to do things differently and engage in different ways to find new solutions. So we, had over 100, this was back in 19, so this is pre-COVID, stakeholder meetings with our cultural brokers. These are employees, 5 employees that we've embedded, 6 now, within community partner organizations who help people navigate healthcare, to help people navigate broad systems, education, housing. So they were able to help us line up the conversations. We had over 300 conversations with folks in St. Paul and the East Metro, and then did in June 2021, a survey of over 1,500 employees, patients, St. Paul residents. This is done in 5 languages. So just wanted to touch on how we collected some of this information. And it really led to, if you wouldn't mind going to the next slide, what has driven our vision. Even at St. Joseph's Hospital, 72% when our emergency department was open, 72% of visits were considered potentially preventable visits. That's an eye opener about the use of primary care. I think Robin mentioned frequent flyers. We call it the high utilizers. We all know that 80 or upwards of 90% of health happens outside of our hospitals and clinics. Half of the residents surveyed, over half, say they face barriers to getting health care when they're sick. And then close to 60% of non-white respondents said they face barriers to staying healthy, even when they aren't managing. So, this data and the information and the conversations driven by community and also obviously, the pandemic and the racial reckoning over the last 2 years, just further reinforced our efforts, further reinforced our resolve to move forward and, shed new light. So for some folks who maybe weren't aware of these issues. So what we are introducing, the big reveal here, the next slide, is the Fairview Community Health and Wellness Hub. You've probably, if you're from the cities, you've probably heard about this and the development of this over the last year. We had a model in place. We have a Eastside Health and Wellbeing Collaborative, a group of over 24 organizations focused on co-design, co-led. We're the convener, but the group identified the issues. They actually have focused over the last 6 years on mental health and stress resiliency and food access. So we had this model. We applied the model to, what is the appropriate response, the reuse of this facility in the urban core. So with community, the convener we served as, but the co-design, we developed, I guess you could kind of call it a one-stop shop for many services related to health, wellness, and health equity. So I think it's similar to Robin, how she described, the approach, our community advancement model is do with and through, not to community. So community advancement, I probably should have introduced as well. It's all of our community health, community relations, local government relations work my teams are involved with, and then our community health equity work, which we'll be hearing about here quickly. And also I'm service president of Fairview Foundations. We're able to align our philanthropy in I think, innovative ways. So we heard clearly from community still the need for comprehensive, integrated, no low-cost primary care services. So we will have, our clinic model downtown after decades of effort just didn't work. And the FQHC model has emerged as most promising for this location and for the population we're serving. So we're working with Minnesota Community Care, the largest FQHC in the state. They're going to be offering services and a clinic on the first floor there, very accessible, over close to 12,000 square feet of patient care space. Used to be a outpatient heart care clinic. As I mentioned, comprehensive services, including pediatrics, behavioral health, basic lab and imaging services. And, in the FQHC model, services provided on a sliding fee and, based on, income insurance status. So we're hoping to serve over 8,000 patients annually. The second component of the hub, I just want to highlight, are some advanced senior day, enhanced, I should say, senior day program and services. So Ebenezer Senior Living, affiliate with Fairview, will be operating a new model of senior day care. The folks are going to be co-located at the hub, so there'll be access to primary care, mental health, pharmacy, other services. This is the first of its kind in Minnesota to have these services co-located and really supporting active independent lifestyles, for underserved St. Paul seniors. So hope to serve up to 70 clients per week. Food access, another issue we heard strongly and clearly from community. We were able to move very quickly before we even had our plans for the hub together last fall in partnering, and we partnered for many years with Second Harvest Heartland and Sane Foundation and a coalition of other food focused organizations. And we just went and toured the site one day with them and looked at the emergency department and ambulance bays and decided, hey, this could be a great hub for food distribution, food storage and distribution, just put the trucks in the ambulance bays. So we turned it around in a matter of weeks before the snow started to fly last fall. And they're using that as a base to supply local food shelves. So that's the first phase, where we responded quickly, but looking at our continued programming and welcoming in more partners for food access and programming at the hub. We also have at the hub, we will have expanded outpatient mental health and addiction services. So ML Fairview is the largest provider of mental health and addiction services in the upper Midwest. This expanded clinic located at the hub, will improve early intervention and support. So, the goal would be to avoid inpatient admission by getting upstream. So also being co-located, that's kind of my theme and the word I've been using a lot within the hub, having resources available for the other partners and the opportunity to expand our services. And then final component of the hub, I just want to highlight is on the point you see there, advancing health equity and addressing the social determinants of health. So we are announcing and will be in July, the official opening of the mHealth Fairview Center for Community Health Equity. So you can see it there on the top left on the second floor. This is actually a space where all my team will be located. So this is, the hub, so to speak, for all of our community health programming, all of our community engagement work statewide. So a lot of activity here, our community clinical work, the over 700 COVID community clinics we've conducted with community partners will be based here and out of, loading up the vans and heading out every morning. So there's going to be a lot of action here. Within the Center for Community Health Equity, there's really three primary strategies. It's addressing social determinants of health, social risks, none of it surprising to you all. And how do we do this through collaboration, research, and then looking at, policy, system, environmental work. Number two is to enhance. We feel like we have a strong community engagement structure in place. I gave the example of the east side of St. Paul, but I think around the state, we've proven, to be a trusted partner. But how can we advance or enhance that engagement infrastructure and enable community voice to inform and influence our institutions? So beyond, the current community health needs assessments, how is community voice driving all strategy for our system? And then third strategy for the Center for Community Health Equity is, transforming and helping to transform our internal structures to create an anti-racist, inclusive environment, and to implement our anchor institution initiatives. So I need to wrap up here, but I wanted to just highlight the anchor institution initiatives that Robin touched on. Our focus on local and diverse hiring, local and diverse procurement, and local and diverse investment. We're just getting our investment underway, and agree with the point. I disagree with the point that community benefit cannot impact because we've led this, but we have C-suite involvement and a C-suite leader who is leading these anchor strategies. So we have goals. This is all done through our lean management process. So there's a A3 for each of these strategies and measurements that go up to the board. So would love to share more on that. I think that's what I touched on those at the initial summit. And with that, I better go because I'm getting the eye from Eric there. Oh, we will have community education space there too. So you're all free to use it for meeting, conference space, and community convenings.
John, a ton of information. Really appreciate it. Sorry I have to rush you, but you are running behind.
And I'm going to also add, that Andy and his team have been incredible partners, and maybe he'll talk a little bit about it, but we've been working with them on the hub and on some other interventions. And I promise I'll put myself on mute now. That was my last point.
Okay, Andy McMahon, United Health Group, is going to move on from here. We're going to keep moving. Thanks, Andy.
All right, thank you, Eric and everyone, and really appreciate the opportunity to join you guys this morning. A real honor and pleasure. So thanks much. And I see a bunch of names that are familiar. So it is very nice to be here. I apologize for being the underachiever of the crowd and don't have slides, but I will be putting in a few links to a couple of the things that I talk about. And yes, John, we are delighted to be working and partnering with John and their team on the Health and Wellness Center. So that is definitely exciting work. I think, from where I sit, when I think about this work, finally it took healthcare too long, but right now, housing is healthcare. I think that's been proven beyond a doubt. And what I challenge my senior leaders within United Healthcare, and I sit within Medicaid, I should say, we have 31 health plans serving 7.5 million folks, including most recently here in the great state of Minnesota. But when I talk to our senior leaders is, okay, we know that. Now, what are we going to do about it differently? What are we going to do differently now? And so I'm going to focus my brief remarks on our investment component. But I want to highlight very quickly that in the 5 years I've been here, I spent most of my career in government and nonprofit. I've been here 5 years. We've created kind of a five-pronged approach to how the role that we as a managed care organization can play in addressing affordable housing issues and the integration of housing and healthcare. So just briefly what those are. First and foremost, for my money, I would take this one 1,000 times as number one is partnerships. And so that's building partnerships with public housing agencies, with local continuums of care, with a host of community-based organizations. I'll put a link into our Catalyst initiative. And to John's point, the Catalyst is something we're doing in 22 communities, including starting in the East Metro with John and a bunch of groups. But to John's point, it's then convening and listening and collaborating, not dictating. I politely tell our health plan leaders, eyes, ears shut. I'm sorry, eyes and ears open, mouths shut, and learn from our communities. So partnerships is a huge for us. Investments, which I'll touch on, is where we've now made over $800 million in affordable housing investments, and I'm going to touch a bit on that. The third strategy is around policy and systems reform. There's a whole host of things we're doing around tenancy supports and tenancy services, waivers in Medicaid and other efforts in the kind of Medicaid landscape. Fourth is our clinical approach for people experiencing homelessness. We have completely redefined our clinical model to best support them through our health and housing team. And the fifth prong of our approach is data and analytics. So that's looking on the front end about how we best target the right intervention to the right person at the right time to be most effective in supporting them. And then on the back end, understanding the impact that this has on utilization and health outcomes. So those are kind of our five-pronged approach. To focus a little bit our work on investments in affordable housing, I'm delighted and proud to say that we've had a long partnership with Greater Minnesota Housing Fund and have invested more than $40 million in affordable housing developments across the state. And I was delighted when Warren mentioned the Steve O'Neill apartments. We actually were the investor in helping to finance and partner with Greater Minnesota Housing Fund on that project. And so that was really, really great. And I would say we are looking now to expand our partnership and are currently in conversations with Greater Minnesota Housing Fund and others, and some of our health system partners, AKA Mr. Swanholm, around where we might jointly have investment strategies. So really excited to expand our footprint and effort here in Minnesota. In addition, I would say we also about 6 weeks ago launched our second $100 million health and housing fund. So we've now invested in the last 2.5 years, more than $218 million through our health and housing fund, which is a partnership with Stewards for Affordable Housing for the Future, SAFE, of which I think there's a few great organizations here in Minnesota. I know for sure Common Bond we've done projects with through our Health and Housing Fund. And so we are continuing that work. And I think from our perspective, I would say our Health and Housing Fund has a few unique features, I think. One is that we are only investing in projects that have some connection between housing and healthcare. So we essentially no longer will invest in kind of quote unquote straight affordable housing projects. We are always going to be looking for that integration and intersection between housing and healthcare. We also, as part of that investment fund, have conceded some level of return on investment to seed a $2.5 million services fund to help ignite some efforts at the projects that we are investing in. And then delighted to say we're also working with SAFE as a housing as a platform tool. And so we'll actually be tracking the resident health and well-being outcomes of the projects that we are investing in. So excited to continue that work and to expand our work here in Minnesota. In terms of the few lessons, I think Eric had mentioned kind of lessons that we've learned or that I've learned for sure. So I would say a few things. One is it's got to be local and you got to listen. So that's kind of first and foremost. If you don't do that, you might as well go home, in my opinion. And related to that is building trust. And that takes time, right? That doesn't happen overnight. Particularly, I fully understand we're a large for-profit insurance company. I also just hope people will look and just see if we're putting our money where our mouth is, because I think we unequivocally are, and so we're really excited about that. And that's how for us we build trust, right? Is the integrity of doing what we say we'll do, and executing on that. Thirdly, is committing to the long term, right? If you're in this for short, quick wins, you might as well go home, right? This is a long game that we have going on here that is really important. And the final thing I'll say for us and in my experience is, I feel like a lot of times we have all sorts of models and approaches and we have project plans and all these things to get all this work done. I will tell you from where I sit, it all comes down to imagination and perseverance, right? We can, all these plans that we lay out, none of them are going to work the way we think. And so for my money, when we're doing this work, and I talk a lot to our UHG Treasury team about this, and I promise it's true. Sometimes people believe me, sometimes not. They actually rarely want to talk about the finances. The finances is math. We can figure out math. The question is, who are the partners? Who are the investors, the people that we're going to work with? Because we're going to run into challenges, right? Things aren't going to work the way we thought. And so you got to have the right people and building the right relationships to do that. So really appreciate the opportunity. I will put a couple things in the chat. Eric, hopefully I did a reasonable job on my speed round, but appreciate the opportunity. And I think my contact information was up there. Certainly happy to catch up with anyone. So thank you very much.
Thank you. And we are having technical problems with the PowerPoint. So, but we do have all of the contact information on the slides, and we'll send the slides out for everyone. I want to mention, just so appreciative of the investments that's being made. The assets from John's example of St. Joe's, again, underutilized property. One of the stories in the newsletter that we sent out was actually around Sanford Health in Greater Minnesota. And this is a really important place. Greater Minnesota and healthcare in Greater Minnesota are really important and very often the highest employers. So an example from Sanford Health is a donation of land that ended up producing veterans homes. When they donated the land, it was the accelerant that brought along all of the other investments that created that resource in northern rural Minnesota. So, so I'm going to finally have Bukata Hayes from Blue Cross Minnesota as the final speaker. And again, if you put questions in the chat, we will pull those and we will try to get out a summary of those questions in the end. So thank you very much. Bukata, you want to?
Yeah, absolutely. Yeah, so good morning, Bukata
Thank you.
Hayes. Yeah, good morning, Bukata Hayes, Vice President for racial and health equity here at Blue Cross Blue Shield of Minnesota. First ever functional area for us is Blue Cross Blue Shield of Minnesota. And so I'll just make my comments really brief because I do want to get to question and answer. I know that's what we want to have an opportunity for. So one, I would say at Blue Cross Blue Shield of Minnesota, we've made investments in social determinants of health for over 2 decades, right? So one of our huge, if you will, splashes on the scene was our suing of big tobacco, right? And how they targeted commercially, right? Underrepresented, marginalized, and oppressed communities. And so through that, we were able to secure a victory and then move to create the Center for Prevention, which has done community-based work around social determinants of health, healthy food access, commercial tobacco cessation, physical activity, and a number of other ways, right, in which we've invested. And then there's also the foundation in which Blue Cross Blue Shield utilizes as a investment arm as well within communities around early childhood, safe and welcoming communities, and then access to insurance, right? So reducing the uninsured rate, or playing our part to reduce the uninsured rate here in Minnesota. And so through those ways, we invest upstream, midstream, and through racial and health equity, we now invest in sort of near-term interventions and remedies as well. And so through that, we continue to play our part in addressing the inequities we see. And so through COVID, through the racial reckoning, Blue Cross Blue Shield declared racism a public health crisis. And so through that work, we said we would show up differently than we had before. We created this position. I partnered with the team. We also have a multi-million-dollar internal spend that we utilize to advance racial and health equity in ways that historically we have not. And so part of that shows up in an effort I'll reference here quickly. And it's around some work we've done in using sort of voice and influence. And it's actually within Brooklyn Center. So we know that in May of 2020, George Floyd was murdered. We know shortly after that, our state has continued to go through instances in which we see Black and brown folks, if you will, victimized, right? And so Dante Wright in Brooklyn Center was killed in a police-involved interaction. And so for us, we saw it as an opportunity to show up differently than we had traditionally. So we are now engaged in a long-term partnership with Brooklyn Center in order to address the many ways in which the public health crisis of racism shows up. One in particular is a partnership with TurnSignal, a digital app that provides legal assistance to motorists to make sure both civilian and officer get home safe in a traffic stop. One of the important things about that I want to mention is that it's also about, that effort is also about mental health. So the idea of the stress and the mental health that in particular motorists of color, Black and brown motorists endure as they make and engage with a police officer during a stop is something that I think we often don't talk about, and we should, right? Much like a nurse hotline provides some sort of calming of fears, anxieties as we work through a tense situation. TurnSignal has proven to do that. TurnSignal has now grown to be available in Georgia, California, Tennessee, and some other places. But we see that as part of showing up differently, right? Understanding that 80 to 90% of health that was mentioned earlier happens outside of interactions with our health plans and with us as providers. So how are we actually showing up in that 80 or 90% becomes the real question that I believe community has a right to ask us. And so to that point, a couple of other things quickly. So one, we do believe community has the answers. There's a Lilla Watson quote that says, if you've come here to help me, you're wasting your time. But if you come because your liberation is bound together with mine, then let's work together. We believe in the concept of shared liberation, that we benefit as an enterprise and communities benefit as well. And so we sincerely believe community has answers. I know Andy mentioned earlier, sort of this idea of listening. We believe in listening, learning, and then partnering, right? Letting community lead. We do not believe we are saviors. We believe if we had the answer, we would have already implemented in a competitive environment like healthcare. We don't have the answer. And so it means we have to partner with community to help find that answer. And I will say in terms of our voice and influence, so we believe using our voice as a leader here in Minnesota is important. So we've testified before the Housing, Finance, and let me get the correct name, and Policy Committee around housing stability and health impacts. We're lending our voice, right, in our investments, but also our voice and influence to talk about the connection between housing and health. And so I think as we wrap up here, we're also working on our Racism as a Public Health Crisis Coalition that will work to embed mitigations to racism within legislation, within systems, within organizations. And we're partnering right now, with Voices for Racial Justice, doing some statewide work with some other partners on that work. So for us, coming out of this, the lesson we learned is we cannot fix what I believe are long-term entrenched racial and health inequities without actually speaking to racism. And so for us as a health plan, we are moving forward and understanding how racism impacts housing, impacts health, impacts health outcomes. So appreciate the opportunity to share. I know I wanted to leave a little bit of time, so appreciate the opportunity to be a part of this panel.
Well, I appreciate it so much, and so does everyone else. And these are all great stories about different uses of assets available in healthcare, from buildings, land, investment, voice, and really an initiative from the Native Community Clinic that is taking that next step. I'm really curious whether there's other clinics that would take that next step to say, we're going to do more and have an impact that's larger than just expanding our clinic. So it's really all impressive work. And you know, we are pretty much out of time, but Kat sent me one question that came up that I think is a good question that's pretty specific. So I'm going to ask it and have each one of you maybe respond quickly, and then we're going to need to close up shop. So where does your institution have current or emerging opportunities which require some community organization partnership? And John, maybe we can start with you, if that's okay, and then just do a round robin so everyone has a chance to think about it. Sorry to spring it on you, John.
No problem. Well, I think it's pretty obvious for me, you know, we're in phase 1 and launching the hub, but I'm looking forward to phase 2. And, you know, what in addition, or what services could we put in, what type of partnerships? So we've had a lot of conversations with folks who maybe haven't been involved to date and would love to engage with you all. I also think, you know, not just limited to the hub, but in all of our community engagement, all of our community health programming, Center for Community Health Equity obviously is an area where we'll be co-designing what it really is with communities. So I don't know if I answered, it was probably pretty vague, but you know, or at the local hospital level, you know, we have advisory groups and community committees serving us.
Great. Bukata, same question around opportunities or emerging opportunities where you think partnership and community could really become strong.
Yeah, so one I think is really clear is the Brooklyn Center work. That's a partnership between the City of Brooklyn Center and a number of community organizations, activist leaders within Brooklyn Center. So I think that's one way in which, if you're in that North Metro, you want to participate, that there's a really tangible way. I think the other way, truthfully, is to continue to push us as health plans and providers to be authentic to the work. I think oftentimes we can sort of, for expediency, bypass certain things. And I think the community continually holding us accountable is critical. So I would say that's the other way.
Thank you. Andy?
Whoop, just getting off mute. Bukata, I think, said it perfectly. I would say for us, very concretely here in Minnesota, is through our UHC Catalyst initiative. Hopefully I can find a link that works. But that is fundamentally predicated on community partnerships and shared decision-making, and shared decision-making both in terms of issues to address as well as shared co-design of interventions to address community and population health efforts, and having a subset of local CBOs are really the heartbeat of those partnerships. And so we're launching our first one in East Metro, but then fast follow on West Metro and Greater Minnesota.
Excellent. Anthony, I'm going to let you wrap that up.
Well, thank you. I appreciate the time to be here and having an opportunity to talk with you all. I think next opportunities, the greatest opportunities we have for moving forward is to continue to build on the relationships we have with Avivo Housing. We're actually going to be opening up a medical operation in their Avivo villages within the next couple of weeks. We'll build on that. 95% of the patients are the people who live in the Avivo villages are Native Americans who are not currently getting healthcare services. So we're going to step into that space. I think the other opportunities we have is to build on relationships that we already have with many of you that are already here. And then also NAC has started to build out a very strong relationship with UHC. They funded a lot of our community engagement work over this last year, and we were really very grateful for that. Thank you so much. And we'll continue to do the things that we need to do, which is move towards crises in our communities and bring all of our partnerships and our resources, both human capital and otherwise, to solve those conditions in our community, because we know that there are other things that our people in our community need to be attending to, rather than those little fires that pop up in their days every single day. So happy for the partnership and happy to build those networks with everybody here. Thank you so much.
Thank you. So it's noon right now. And so I need to sort of wrap this up. I don't want to take more time, but I want to thank all of our panelists and our speaker today. Very helpful. It's been, I want you to know that we're planning another event in July around housing stabilization services, which is a, Medicaid funded housing supports that's, taking hold in Minnesota and a real opportunity. I also want to know that we'll get the PowerPoints out. We'll follow up with the survey as well, looking for the priorities. And finally, if you go to our website, there's also a Tell Your Story button on the Health Equity website at the Greater Minnesota Housing Fund. And we really want to collect more stories to be able to raise those up, share them across the field. And I think that's really important. I see Ruben Moore, who has his hand up. And now I'm venturing to see whether this is something that we can fit in, Ruben.
I might be best to close this meeting because I've led in this space both in the as the largest FQHC in the state, and also standing up a $50 million health as housing project. And we hope to get this in front of UHC and other partners, where we're examining multi-generational housing right in the heart of the East Side at the old 3M headquarters, the founding site of 3M. This is a breakthrough project, and I think I'd love to get the partners on this table to be more curious. We're going to have a plethora of community integrated services. We've looked at the best practices across the country, and I'm glad that we're all in the room now seeing this really delicate convergence in terms of social determinants of health and coming together as healthcare being the new solution for our housing crisis in our country. And so as we wrap up, let's keep our energy alive, and please include me in all the next sessions.
Hey, Ruben, thank you. That's actually a great way to end it. I wasn't aware of the project. Now I'm going to follow up with you directly. I want to have a conversation, and I hope that you'll reach out to us, because we really do want to facilitate relationships between healthcare leadership, housing leadership, service leadership. So we're out of time, and I thank everyone for being here, and I'm sorry we had to rush a little bit. Thanks so much.
Thank you.
Thank you all. Bye. You go, woman.